Turning to malaria now, results from a large-scale phase 3 trial show that the RTSS malaria vaccine candidate can help protect African infants against the disease. When administered along with the standard childhood vaccines, the efficiency of RTSS in infants aged 6 to 12 weeks at first vaccination against clinical and severe malaria was 31% and 37% respectively over 12 months of follow-up after the third vaccine dose. 11 African research centers in 7 African countries are conducting the trial, together with GlaxoSmithKline and the PATH Malaria Vaccine Initiative, with grant funding from the Bill and Melinda Gates Foundation to MVI. The study was published in the New England Journal of Medicine. And for more discussion on malaria and the study, we are joined live via Skype by Dr. Patricia Njuguna, a pediatrician. She is the RTSS principal investigator and lead researcher at the Kemri Wellcome Trust Research Center in Kilifi, Kenya. She is an author on the journal paper with the latest results on the RTSS malaria vaccine trials. Dr. Njuguna, welcome to In Focus.
Thank you very much.
First of all, tell us more about these findings and what do these results demonstrate in terms of the efficacy of the vaccine?
So as we said, these are the results following the conduct of a large phase 3 trial across sub-Saharan Africa in 7 countries. The critical findings that we're able to show is that this vaccine has an acceptable safety profile when administered to infants aged 6 to 12 weeks over a 1-year period. We are also able to protect a third of the kids, a third of the children against clinical malaria and severe malaria. And that, when compared to the burden of malaria in Africa, is quite a significant problem.
Now, when we look at this percentage, 31 and 37%, what do you think in terms of the efficacy? Do you think that's a good enough percentage that is okay to proceed with this vaccine, or is there more need for research?
So do I think this is good enough? We'd always want to see 100%. I mean, but this is quite interesting data to us as scientists. What we'd like to see, as we said, this is an ongoing trial. There's key data that's coming to us within 2 years, where we'll be able to look at the potential usefulness of this vaccine in this age group. We have been able to demonstrate in the older age group that we're able to protect at least half of the children against clinical malaria and severe malaria. And so we think that this vaccine still may have a place within the background of other malaria interventions, such as bed nets and appropriate treatment and diagnosis of malaria, so to join the toolkit against the fight against malaria.
Now, in previous research, there was, in previous trials, there was a 56% reduction in clinical disease and 47% reduction of severe disease in children aged 5 to 17 months. Why is there a difference in terms of efficacy with regards to these different age groups?
So I think that's a good question. As we said, in the previous results, we were able to show that a 56% efficacy against clinical malaria and 47% against severe malaria. And in the infants, we've shown slightly different data where we're able to show slightly lower protection. Why do we think this is a difference? We obviously don't know at this point, and we're hoping that we'll have more data that will help us look at this. But what we think are possible explanations include that these children are quite young, so their immune system would be quite immature and therefore maybe not able to process the vaccine responses as appropriate. And this has been seen across other vaccines. We are also giving this vaccine alongside with other vaccines, and there could be immune interference between the other vaccines and RTSS. And also the protection of maternal antibodies. Children are born with antibodies from the parents, so that they would be able to protect themselves against infections, and that may interfere with immune responses to vaccines, and this has been shown with other vaccines such as measles. We also cannot really say, but there could be an influence of the transmission intensity, the burden of malaria. So this vaccine is done in areas where there's a lot of malaria and very little malaria, and this is combined across all the 7 sites, so difficult to interpret at this point.
Okay, Dr. Njuguna, thank you so much for joining us. That's all the time we have for today.
Thank you very much.
And that was Dr. Patricia Njuguna. She is an RTSS principal investigator and lead researcher at the Kemri Wellcome Trust Research Center in Kilifi, Kenya. And that's our Africa Health Network report for today. For more health news and developments, be sure to visit our website at africahealthnetwork.com. Vincent Dimiake, back to you.
Thank you very much, Linord, for being here today. And be sure to watch for Linord Moudou's Africa Health Network reports every Tuesday and Thursday right here on In Focus.